Aloha, welcome to our program today. Thank you for joining us. My name is Dr. Violet Horvath, and I'm Director of Pacific Basin Rehabilitation Research and Training Center. And our program today is about the Hawaii Neurotrauma Registry with a focus on stroke. We have a stroke specialist here with us today that I'll introduce in just a moment, who's going to give us all kinds of valuable information, along with my telling you a bit more about the Hawaii Neurotrauma Registry. So let me introduce a couple of important folks here. First, our stroke expert, Dr. Matthew Koenig, who is a neurologist at Queens Medical Center and an assistant professor at the John A. Burns School of Medicine. I would also like to introduce Miss Patty Sakal, who is our American Sign Language interpreter, who is from Hawaii Interpreting Services. Let me start by telling you a little bit about the Hawaii Neurotrauma Registry project. My organization, Pacific Basin Rehabilitation Research and Training Center, is contracted by the Department of Health to administer this registry, which is a survey for any resident of the state of Hawaii who's had a stroke, a traumatic brain injury, or a spinal cord injury. Now, you could have had that injury at any time, at any location. The only criteria is that you're a resident of Hawaii. Okay? And why is this registry important? Well, we've discovered that we know a lot of things about people when they're in the hospital. We know a lot about when they're at the rehab facility. But the Department of Health doesn't really know what the needs are of people once they leave the hospital or the rehab facility. So this information is critically important to let them know so that they can better plan the services and the policies that are needed for people who have experienced a stroke, a traumatic brain injury, or a spinal cord injury. We also do education of the public on these neurotrauma injuries. We also offer an individualized, personalized information and referral service for any resident of Hawaii who has experienced a stroke or a spinal cord injury or a traumatic brain injury. Now, you want to get a piece of paper and a pencil or a pen handy, because at the end of the program we'll show you the contact information. You can call us, you can go online and take the survey, you or your caretaker or family member can call and get that personalized information, those information referrals that I talked about. But let's get to our expert here today. And as I mentioned, we're going to focus on stroke in this program. So, Dr. Koenig, what actually happens when someone is having a stroke?
Well, thank you for inviting me on the program, Violet, and thank you for the opportunity to do a little bit of education about stroke, because I think there's a lot of misperceptions about what stroke is. And I think a lot of people have a rough understanding of stroke, but sometimes they have trouble differentiating it from a heart attack or seizures or other serious conditions. And stroke is caused by a blockage in blood flow to the brain. And the most common cause of that is when a blood clot is carried along the bloodstream. It can originate from the heart or another blood vessel, is carried along the bloodstream and then lodges in the blood vessels of the brain and blocks blood flow to part of the brain. And if blood flow is blocked to part of the brain for long enough, it causes a permanent injury. Now, I know that sometimes a picture is worth 1,000 words, so I brought a slide of what I mean by a blockage of blood flow to the brain. And it's shown here, where on the slide on the left, you see a blockage in normal blood flow to the brain. And this slide is actually looking at the blood vessels at the base of the brain. And then the slide on the right actually shows the decreased blood flow in that area, that large area of red that's occurring when that blockage occurs. And so stroke really is a death of the brain tissue that occurs when there is no blood flow to part of the brain.
And I've heard the terms, and maybe some of our audience have heard it too. There's a hemorrhagic stroke and an ischemic stroke. What are the differences?
That's because in medicine we like to confuse the public and make things complicated.
Well, you're doing a good job.
So the term stroke applies to what I just said, which is a blockage of blood flow to the brain resulting in a permanent death of that brain tissue if the blood flow is not restored fast enough. There's also a subset of strokes that we call hemorrhagic stroke, and hemorrhagic is a fancy term for bleeding. And basically what that is it's not a blockage of blood flow to the brain. What happens instead is that one of the blood vessels breaks open and spills blood into the brain or around the brain. And it's lumped together with stroke because when that blood is reabsorbed from the brain, it leaves behind a scar or permanent injury. And that can look very much like a stroke, and it can cause disability very much like a stroke.
Oh, okay.
So the ischemic stroke, which is the first stroke that I mentioned, blockage of blood flow to the brain, is much more common. It's about 80% of strokes, whereas the hemorrhagic or bleeding strokes are about 20% of strokes.
And then what's the average age of someone getting a stroke?
Stroke is most commonly a disease of older adults. It generally occurs in people in their 60s and 70s and sometimes older. But we do very commonly see strokes in younger people. Sometimes even children can develop strokes. And then a lot of patients, we see a lot of patients in their 30s and 40s even with strokes.
Well, I know that there was been some recent research that is showing that more and more younger people are having strokes. Now, why is that? And I know some people think it's because of drug use.
That's a great question. And that's a common question that I get asked, actually, is that when younger people have strokes, is it always because of drug abuse? In particular, methamphetamine or ice is a prevalent drug in Hawaii. It's kind of a scourge in Hawaii in a lot of ways, and that can result in strokes in younger people. But that's actually not the most common cause of strokes in younger people. The most common cause is untreated high blood pressure. And high blood pressure is the major risk factor for stroke regardless of age. And so most commonly when we see younger people with strokes, it's not the result of drug abuse. That can be a risk factor, but that's not the most common risk factor. And in general, it's that the person either had high blood pressure and didn't know it, or had high blood pressure and knew it but was not being treated for it.
Well, I could see how somebody younger would not ever imagine that they might have high blood pressure. Okay, interesting. Now, of course, with just about everything, prevention is going to be the best thing. Don't have it, if at all possible, to begin with. So what are some of the things that people could do to try to lower their risk of stroke?
That's a great question, and I brought another slide here of risk factors for stroke that we could pull up as I talk. But the most common risk factors for stroke are high blood pressure, high cholesterol, a sedentary lifestyle, meaning not being active, diet, certainly diets that are high in cholesterol are a risk factor for stroke. Smoking is a risk factor for stroke. And then a heart condition that results in an irregular heartbeat that's called atrial fibrillation, which is very common among older adults, is a major risk factor for stroke. But really the most common risk factor for stroke is hypertension or high blood pressure. And when I talk about stroke, either with the public or when I educate medical students at the School of Medicine, I always like to emphasize that stroke is really a disease of hypertension. That the best way to eliminate stroke is to treat high blood pressure. And there's a very strong relationship where even reducing the blood pressure by 5 points or 10 points has a very high reduction in your risk of having a stroke.
And so with high blood pressure, treating high blood pressure being so important, what are some ways that people could lower their blood pressure?
The first line method of lowering blood pressure is actually to increase exercise and reduce weight and reduce what we call sedentary lifestyle. That's generally the first line therapy. If changes in diet, becoming more physically active, and reduction in weight are not successful, then the second line treatment are medications. And blood pressure can be very difficult to control, and there are many patients who require multiple blood pressure medications to lower their blood pressure. And I actually have to, I will tell the audience that I actually have high blood pressure. And I take 2 medications at relatively high doses to reduce my blood pressure, even though I'm physically active. And so it just emphasizes that people who do try to lead a healthy lifestyle often do need medications to lower their blood pressure.
Now, let's say, and I know of people who've had this, they have been an active lifestyle, they might be on blood pressure medication, they don't have diabetes and so on. and yet they still end up having a stroke. So what are the signs and symptoms of a stroke?
That's a great question, and thanks for bringing that up. So along with not having a clear picture of what stroke is, I think there are many in the public who really would not be able to recognize a stroke if someone was having the stroke. The problem with a stroke and how it differs from a heart attack is that I think most people would be able to recognize symptoms of a heart attack. A heart attack is characterized by chest pain, and chest pain drives them to actually seek medical attention. If you're having pain, it makes you go to the emergency room or call your physician. Stroke affects the brain. And so in affecting the brain, the person who's having the stroke may not be thinking clearly, whereas a person who's having chest pain is otherwise thinking clearly and makes a rational decision to seek medical attention for that pain. Stroke is usually not painful, and it alters the function of the brain, and so people are not thinking clearly when they have a stroke. And so even beyond educating people to recognize signs and symptoms of stroke in themselves, it's very important for the general public, even young people who are at low risk of having a stroke themselves, to be able to recognize the signs and symptoms of stroke in others. You know, for example, even school-age kids, if they were taught to recognize what a stroke looked like, might be able to really save their grandparents or their parents if they could see those stroke symptoms.
So is there an easy way to remember what the signs and symptoms are?
There is. And I actually brought another slide that has the ACT FAST, which is a sort of memory tool that you can use to remember the signs and symptoms of stroke. And so ACT FAST, the FAST part stands for face, and very commonly stroke results in a droopiness of one side of the face. Okay, it's important to emphasize that when stroke occurs, the deficits are usually on one side of the body, or paralysis or sensory loss on one side of the body.
But it could be either side.
It could be either side. It could be left or right. That's correct. And so the F stands for a facial droop or droopiness of one side of the face. The A stands for arm weakness, or if someone has weakness of one arm is strong and the other arm is weak. The S stands for speech, which can be slurred speech or garbled speech that doesn't make sense.
So you should ask the person to try to say something.
That's correct. So for the general public, if you're concerned about someone having signs of a stroke, ask the person to smile and look for a facial droop on one side. Ask the person to hold their arms out in front of them and look for a drift or a weakness of one side. And then have the person speak and see if the speech is garbled. And the T stands for time to call 911. So face, arm, speech, and time to call 911. And that's ACT FAST.
And that last one is one of the most important things, right?
That's absolutely true. And we use a memory tool for the public that says time is brain. And what time is brain means is that when you have a blockage of blood flow to the brain begins to experience permanent injury very quickly, within minutes of loss of blood flow. And the data is that when you block blood flow to part of the brain, neurons, which are the brain cells that do most of the work of the brain, begin dying at a rate of 1.9 million neurons per minute after the blood flow is blocked, until that blood flow can be restored by medications. And so it's very important that people seek medical attention as quickly as possible after the symptom onset, because the time for treatment is very short, because permanent injury begins to set in even within minutes. And that's why it's important that if you recognize the signs and symptoms of stroke in another person, we want you to call 911. It's very important that people call 911.
Well, why don't I just get in my car and go?
That's a great question, and a lot of people do that, unfortunately. Actually, only about 60% of our patients in Hawaii who are having strokes arrive at an emergency room by an ambulance, which is not good. We want 100% of patients to arrive by ambulance. And the reason for that is that the treatment and evaluation of stroke begins with the paramedics. It begins in the ambulance. In Hawaii, neurologists and emergency physicians and the Department of Health and the American Heart Association and other organizations have gotten together as a statewide group to really design a stroke system of care. And that stroke system of care means that when you call 911, it doesn't matter where you are, what island you're on, what zip code you're in, what city you're in. When you call 911, you will be evaluated by a paramedic who has been trained to recognize a stroke when they see it. the paramedics perform a standard battery of tests called the LA Pre-Hospital Stroke Screen and can recognize signs of stroke. What happens when they recognize those signs of stroke is that they phone ahead to the emergency room and they activate the stroke code system, which basically gets all of the stroke providers ready for the patient before the patient even arrives. And that way, when the patient arrives at the door to the emergency department, the wheels are already in motion to begin the process of evaluating the patient very quickly and treating very quickly. And that has resulted in very significant decreases in the amount of time that's lost from the time the patient hits the door to the time the patient receives medications.
Well, that's great here on Oahu, but what if somebody lives on the Big Island or Maui or Kauai or Molokai?
Right, it's a great question, and even on Oahu I get asked this question often by members of the public, is that if I'm in X, Y, or Z city and I call 911, how do I know I'm going to be seen by a stroke expert, or how do I know that I'm going to be treated appropriately for my stroke? You know, maybe it's better for me to wait for my daughter to come home from work and drive me to a different hospital where I'm more confident that I'll be treated appropriately. And so that's really why we got together as a whole state. All of the hospitals in the state have representatives at the stroke task force meeting to pull our resources so we take care of stroke patients in the manner that's state of the art. And so I can assure the public that if you call 911, you'll be evaluated by a paramedic who knows what they're doing, who's been trained to recognize stroke. That paramedic is directed to take you to a hospital that can treat stroke, that has stroke expertise available. And the hospitals in the state are working together to provide that.
So one of your main projects is the telehealth, the telemedicine. Can you tell people a little bit more about that, what exactly that is?
That's right. Thanks for the plug.
Very important. It's very important.
Thank you. So I'm also the clinical lead of a telestroke project, which is a stroke telemedicine project. When I say telemedicine, what I mean is two-way audio-visual telecommunications. So I can log on to a computer very quickly at my home or in my office or on the go. And after I log on, I can see the patient who's in the emergency room at another hospital, let's say Molokai General Hospital, for example. Mm-hmm. And the patient can also see me, and then I can speak to the patient, and the patient can speak to me. And in that way, even though I'm not physically located in Molokai, I'm here in Honolulu, I can evaluate the patient myself. I can take my own history. I can examine the patient. I can discuss risks and benefits of treatment, and I can make recommendations for treatment. And so that gives patients, even on the neighbor islands, the availability of having a stroke expert through telemedicine who can see them at hospitals that don't have a neurologist on site 24/7.
Wow, that must be very comforting to people on neighbor islands to hear about that, because I know they often think they kind of get forgotten. We know there's been a lot of news lately about physician shortages here on Oahu, but especially on neighbor islands, and especially very difficult to get specialist help.
That's absolutely right.
And you had mentioned this, I wanted to go back to it a little bit. You mentioned the treatment that's available, and you talked a little bit about the outcome. So timeliness being a factor, if people get there faster and they get the treatment, can you tell us a little bit more about the outcomes that are possible? Okay,
so I do definitely want to say a few words about treatment of stroke. Okay, so the real treatment of stroke is prevention of stroke. Okay, and we talked about that quite a bit, especially treatment of hypertension. And so my goal would be that I never have to treat stroke, honestly, that people don't have strokes, that strokes are prevented. You don't want to have a stroke and have to have it treated. What I want people to know is that stroke is a treatable disease. A lot of times people see stroke as an endpoint, meaning the stroke is done and there's nothing to do about it, and you can do some physical rehabilitation, but there's no treatment of the stroke itself. That is not true anymore. Stroke is now a treatable condition, but it has to be treated very, very quickly. The time window for treatment is just a few short hours, between 3 and 4.5 hours from the time of symptom onset. And unfortunately, that means that at this point, we're only treating the minority of patients who have strokes. And so in Hawaii, looking back at the data over the last 5 years, we're only treating between 6 and 8% of patients with strokes. That means 92 to 94% of patients who have strokes do not get treated with clot buster medications, meaning trying to restore blood flow to the brain. And so part of that is that the public is not able to recognize what a stroke is, and they wait before coming in. Part of it has to do with efficiencies in the system of care that we're working on to speed delivery of the medication to patients who need it. But we really need to work together, physicians, hospitals, and the public, to become more efficient in how we treat patients with stroke so we can raise the number of patients who can receive that available treatment. And so the treatment is a medication called alteplase, which is most commonly known as TPA. There's actually only one drug on the market. So I'm not here to plug a specific brand name. There's only one brand name on the market. So alteplase is TPA. It's actually a naturally occurring chemical in the body that breaks down clots. And it's given as an intravenous or IV dose, infused over about an hour. And the medication has been shown to reduce the risk of chronic disability associated with stroke. It's not a perfect drug. It doesn't work for everybody. And it's a clot buster medicine, which basically means that it goes to that blockage in blood flow to the brain and breaks down the clot and restores blood flow to the brain. And if that blood flow is restored quickly before permanent injury sets into the brain, then the symptoms can be reversed. And I've certainly seen patients who are treated within an hour or 2 hours of onset of even severe symptoms experience complete or near complete recovery with that medication.
Wow.
More often, there's blood flow is restored, but there's some damage that's already done. But what we know about TPA, the clot buster medication, is that for the right patients, meaning patients who can get the medication quickly enough and don't have other major risk factors for bleeding, that patients are better off in the long run if they are treated with the medication than if they don't get it.
And we've been talking about this statewide, and I know you brought a slide today that has a graph on it that looks at differences statewide. If we could see that slide.
Yeah, thanks. You remember my slides better than I do.
That's my job.
So I think what we're talking about is that there are disparities in actually in the incidence of stroke, meaning the number of strokes that occur, but particularly in the mortality rates, meaning the percentage of people who die from strokes. There's a lot of disparity among the different islands and among the different ethnic groups. And so this slide actually looks by county, looks at the different islands, and as you can see, these bar graphs show the stroke mortality, which means the number of people who die from stroke per 100,000 population. And as you can see, the bar graphs are not even, which means that there are a higher number of people who die from strokes on the big island of Hawaii and also the island of Kauai compared to Maui and Oahu. And so more people are dying, more people are dying from strokes on Kauai and Hawaii. Some of that has to do with some of the issues we talked about, like access to care. Some of it has to do with geographic differences. For example, the island of Hawaii, the big island of Hawaii is larger, and so the drive time differences to an emergency room are longer. And some of it has to do with ethnic or racial differences in the island. And so there's a second slide that actually shows the differences in stroke mortality by different racial or ethnic groups. And this slide really emphasizes the fact that our Filipino members of the community and the Native Hawaiian members of the community have excess mortality from stroke, which means more Native Hawaiians and more Filipinos are dying from stroke compared to whites and Asians. And the reason for that is not immediately clear. What I can tell you is that, I'll put in a plug for my colleague, Dr. Kazuma Nakagawa, is a neurologist who works with me at Queens Medical Center as well, and he's actually dedicated his research career to trying to answer that question, to trying to figure out, specifically for the Native Hawaiians and other Pacific Islanders, why the stroke mortality is higher and why the rate of bleeding strokes is higher and what their specific risk factors are. Are they genetic factors? Is it more high blood pressure? And sort of tease out what that is and how we can lower that number.
Wow, that is some incredible information, and thank you for that. And so I have one more question for you. So we're here to talk about the Hawaii Neurotrauma Registry. So why, as a physician and as in your personal life, why would it be important for people to join the registry? That's
a great question. And what I can tell you is that as a neurologist, I'm pretty good at predicting what a patient will look like after a stroke when they leave the hospital. I'm okay at predicting what that person will look like when they leave rehab. And I'm probably so-so at predicting what that person will look like at 6 months. Mm-hmm. Beyond that, we're not very good at knowing how patients live with stroke chronically. Mm-hmm. We're not actually even very good at knowing the numbers of people who live chronically with stroke. So I could give you a lot of numbers about the incidence of stroke, meaning the number of strokes that occur, new strokes that occur per year. But the prevalence of stroke, meaning how many people here in Hawaii are living with stroke, that number we don't really know. It's very, that number is more elusive, and that's because we in medicine, and I myself am guilty of this, we focus on the acute treatment of the disease, but the chronic disability that people have and how they're living with that disease more long term has not been a focus in our research. And so that's why I think that it's very important for us to change that and really get a much better understanding of what it means to live with stroke here in Hawaii. Mm-hmm. I think the registry does that.
Yes, thank you for that. And Dr. Koenig is absolutely right. As I mentioned at the top of the show, this is the piece of information that we are missing. We don't know what is needed, what happens to people once they leave the hospital or the rehab facility. And I really want to commend the Department of Health for taking this action to try to find out. So we desperately need your information. If you have had a stroke, a spinal cord injury, or a traumatic brain injury, please consider joining the registry. Also think about your children, your grandchildren, other family members, your friends, your coworkers. They might have had one of these neurotrauma injuries. Please tell them about us. And remember too, we have the ability to offer that personalized, individualized information for any Hawaii resident, whether they choose to be in the registry or not, to help them, to give them the information and referral they need to get the services that they need. Thank you so much for joining us today. I hope you learned as much as I do. I really appreciate what Dr. Koenig brought. And thank you and aloha.